I'm the superintendent of Hempfield School District, and on behalf of all the superintendents and our partnership with Penn Medicine LGH, we're very grateful that we're able to bring this to you, to all the athletic directors across the county. And so this afternoon, we're able to provide this not only because of our partnership with Penn Medicine LGH, but also because of our county commissioners. They have allocated federal dollars for all the school districts to be able to have this consultative support with Penn Medicine. So we're extremely appreciative not only of our Penn Medicine partnership, but also the work that the commissioners did to support this initiative. So this afternoon, we're excited to bring to you Dr. Marino. Dr. Marino is the managing physician at Penn Medicine LGH with regards to the general health physician sports medicine. And so we are recording this session. And as Dr. Marino is presenting, if you have questions at any time throughout this presentation, please post those questions in the chat box. And when Dr. Marino is finished with his presentation, he'll be able to see those questions in the chat box and be able to respond depending on the time frame that we have left. If we can't get to all those questions, we'll certainly work to provide answers to those questions through our FAQ documents that we're sending out to school districts. So thank you again for joining us. And Dr. Marino, I'll turn it over to you.
All right, thank you very much, Mike. Can everybody hear me okay? Excellent. Great. Well, it's a real privilege to be able to talk to you, and thank you so much for your attention today, for sparing your time. I know it's time is very valuable for everybody, especially this time of the year as we look at sports getting kicked off in a very different, unique circumstance. I am really thankful too for the collaboration between Hempfield, the superintendents, the Lancaster County Commission, the IU13, and with Penn Medicine, Lancaster General Health. So as Mike said, I am the managing physician here for our sports medicine program. I am also the team and school physician for Conestoga Valley School District, as well as the team physician for Lancaster Mennonite High School. I work with the Lancaster Barnstormers and with USA Women's Field Hockey. So as we're getting started here, some of the objectives for this discussion. Just wanted to provide a brief update on COVID. Ask this question, is it safe to play sport during a pandemic? Because fundamentally, I think that's one thing we all need to be able to get behind. Understanding the risk of sport, understand what's happening in our county currently, as well as knowing what the current PA-DOH recommendations are. I'd like to give a little bit of a brief update as to how LGH and the schools can work together, what resources are available, and then really challenge all of us to have a few action steps for school athletics coming away from this discussion. So I'm going to steal an analogy from Dr. Jeff Martin, who is the chair of our family and community medicine, as well as overseeing the contact and tracing efforts for Lancaster County. And his analogy is that back in March, if we can go back and think that even in February, so a little over 6 months ago, there really weren't too many Americans that really had COVID-19 or pandemic on our radar. And it hit us so quickly that it was almost like traveling into a tunnel without any lights on at 100 miles an hour. I'd like to think that things have slowed down a little bit since that time, but we're still traveling through this tunnel. Maybe we can see a little bit of the light at the end of the tunnel, but things are moving very quickly. And I think that goes to the point that what we knew last month, we know more now. And in another week and another month from now, we'll have even more information and we'll be in a better position. And I think what we can do is try and understand to the best of our ability the knowledge we have now and be ready to adapt and be flexible as new information comes in that helps us manage this pandemic a little bit better. A little bit about COVID-19. The virus, so you may see this terminology, COVID-19, SARS-CoV-2, and coronavirus used interchangeably. Well, Coronavirus refers to this family of viruses of which the novel or new SARS-CoV-2 virus is a part of. And it's SARS-CoV-2 that is responsible for our current pandemic. The disease that SARS-CoV-2 causes is called COVID-19. And really, it's interesting, this is the third novel coronavirus outbreak in this century. SARS-CoV-1, which was previously just referred to as SARS, and then also the MERS virus. All of these coronavirus pandemics or outbreaks have originated from an animal species and have somehow transitioned or made that leap over into the human and being able to infect humans. We're not completely clear how it made that jump, but it probably came from bats and then used an intermediate vector to make that jump. SARS-CoV-2 is spread most commonly by close contact with respiratory droplets generated by sneezing, coughing, or talking. It can also be transmitted by contamination with hands that have those respiratory droplets on them. It can be transmitted through the eyes, through other soft tissue, or mucous membranes. But it's a little bit less easy to transmit through the nose, mouth, etc., from contaminated surfaces. A lot of studies are out there around how far these droplets, respiratory droplets, can speak or can travel. And that depends too upon, I guess, the type of activity and how you're speaking. Typically 6 feet we feel is fairly safe and that they don't travel more than that. But there might be scenarios such as singing, or we could imagine on the sidelines being very vocal or trying to communicate with our teammates, our coaches, that those respiratory droplets could transmit even or project even farther. Current symptoms for coronavirus, there's a whole list of them that continue to, that have evolved over time, but primarily fever, cough, fatigue, and shortness of breath are the big ones. Muscle ache, sore throat, this loss of sense of taste of smell, diarrhea, nausea, and vomiting, and even some congestion or runny nose could all be symptoms of coronavirus. Infectivity can happen 2 days before somebody presents with symptoms or develops symptoms. So we really look at that 48-hour window before a person develops symptoms and then tests positive for COVID in regards to who did they come in close contact with and who might be at risk for being infected at that time point. And about 8 days of illness is when their viral level drops enough that we feel contagion is less likely to happen. And so you'll see a lot of current recommendations stating that 10 days after the start of symptoms, that is, someone may be cleared to return to work or to school as long as they're symptom-free. It's also important for us to note, and I think we've heard about this, that people can be infected without ever having symptoms. We call that asymptomatic spread. As I mentioned a little bit, the risk of transmission depends upon the type and duration of exposure. So it's not just were you within 6 feet, but how long were you within that space? What kind of activities were going on during that time period? So one rule of thumb is about 15 minutes and 6 feet of contact. Because we know how it's transmitted through respiratory droplets, the methods we use to mitigate transmission is based upon blocking those respiratory droplets and protecting our eyes, our nose, our mouth from absorbing or being exposed to them. And so masking and hand washing become a real, like the cornerstone for prevention here. If you're in a very close contact with somebody, let's say you live in the same household, those cases, that seems like infectivity is a little bit higher. You're more likely to contract it. And there have been different special groups that have seen outbreaks, whether it be in nursing homes or potentially in choir groups, large religious ceremonies, bars, restaurants, and even meetings and gatherings that were happening in person before we all started using Zoom. Indirect contact, like passing someone on the street or in the store, it's pretty low risk for infection. What does that infection look like? Well, incubates in the system, and sometimes that can take up to 14 days for you to begin to develop symptoms. So if you are exposed to the virus and then on day 0, you may not develop symptoms until 14 days later. Most people will develop symptoms around 5 days after exposure within that time period. But that's one of the reasons why we have the quarantine for potential exposures that last for 14 days. Even though there's a wide range of symptoms, the majority of people will at some point in their course of illness have a fever, cough, or fatigue. There are several risk factors for severe advanced disease. And this is more well studied in, or we have more knowledge about this in adult population. But anyone with chronic conditions such as diabetes, emphysema, asthma, immunosuppressive state, they're more likely to have a more significant or severe course of illness with coronavirus. These mortality rates differ quite widely. If you've seen any of those studies, it looks very different across the world as to how many people are both infected, but also how many people have died from coronavirus. We do know that children are infected at lower rates. And in Pennsylvania, it was about 276 cases per 100,000. And that's compared to adults who had 922 per 100,000. But this seems to be changing as well. And we're not entirely sure why, but several studies, the American Academy of Pediatrics has reported an increased number of pediatric cases over August. And really the cases grew across the country by about 21% in children through the month of August. So it'll be interesting to continue to monitor that as we now move towards more close gatherings with school opening. Fortunately, even with that, the mortality rate remains fairly low for children, with essentially no deaths in the state of Pennsylvania related to COVID-19 in the pediatric population. But they can still get sick and they can transmit it and act as vectors. And I think there are some other concerns about what being infected with COVID-19 implies for our athletes, and we'll touch on that in a little bit. So another comparison here of COVID with some other illnesses. You may have heard people liken this to other pandemics or other flus that have come across. This is different than seasonal flu. It's different than measles. On this chart, you can kind of see a comparison of different viral illnesses and where they fall in terms of mortality and where they fall in terms of infectivity. And if you look on the further you go to the right means how quickly it spreads and can be infect one another. And the further up you are on the scale, then the higher the fatality rate. You can see that the coronavirus we estimate falls somewhere in that range of that red box, which puts it a little bit more infective and a little bit more fatal than the seasonal flu. We already talked about prevention a little bit, but masks are really highly effective at this point. There was a period of time where there was discussion about lack of evidence for masking, but really based on our knowledge that we've learned in some newer studies looking at the trends of infection of COVID-19 since we instituted masking policies, we have seen that those infection rates have decreased. And it does seem to be infected, and it's now recommended, of course, by the CDC and the PADOH. Hand washing, of course, is important. Physical distancing as much as we can. And then disinfecting surfaces, although I think surface contamination is probably a lower risk of transmission than direct contact. So you're going to see all sorts of masks and read all sorts of information about masking. The point here is that we're trying to protect our eyes, nose, and our mouth, especially with the mask, our nose and our mouth. The CDC recommends having a covering that's made of cotton, silk, or linen. They recommend 2 layers of tightly woven cotton fabric if you make your own, and it should fit snugly around the sides of your face. The following types of masks are not really preferred, and that would be bandanas. And gaiter masks should not be preferred either. And there's a recent study that came out suggesting that gaiter masks may even be worse than not wearing a mask at all. We don't fully understand why that is, but we know that they're not effective in blocking the droplets. And the CDC does not recommend any mask that has an exhalation valve or a vent. So let's dive in a little bit more specific to sport and what COVID means to sport. And let's understand that we don't have a lot of knowledge about this yet, and we're learning a lot more every week. It's really not, while this is the first time we've been here with coronavirus, it's not the first time we've addressed sports during a pandemic. This picture comes from the 1918 influenza pandemic. You can see the players here wearing masks, umps are wearing masks. And even in the background, which is a little bit fuzzy, you can see spectators are allowed and they're wearing masks. They're not necessarily socially distanced back there, but it goes to this principle of masking has been effective for other viruses that spread through respiratory droplets, and we know that it is being effective for coronavirus as well. And it's something that we can use in sport. So you probably have all talked, or at least weighed this question in your mind. Is it safe to play sport? And it's really not a very simple or straightforward question. And it depends on many, many factors. I do think that some of these factors are in our control and some of them are really not in our control. So we have to approach this with a lot of respect for everyone that doesn't share a particular viewpoint, but also with listening ears so that we can have meaningful dialogue around this. Again, as I mentioned before, we're only 6 months into this virus and we're learning things at a rapid pace. So we have to recognize that our knowledge is going to continue to expand and we need to be able to grow and adapt with that and make those decisions accordingly. Individual health plays a big role. Our community plays a big role. I think socially, taking into consideration your socioeconomic determinants for health makes a big difference. Your age, there are some race and ethnicity concerns. We do know that our African American population those communities do seem to be hit harder by coronavirus than some other communities. We need to be aware of our own ability to do effective contact tracing in our community, as well as can we do timely testing? What kind of health infrastructure do we have? And really understand that we may be bringing our own perceived risk to sport based upon our past experiences or where we're getting our sources of cultural knowledge. I think social media is going to play a huge role in framing that as well. So from my standpoint, I try to maybe simplify this question down or boil that question about is it safe to play sports into 3 key questions, which I believe we need to have answers for. And one is, can we protect our players? Second being, can we protect our staff? That includes coaches and volunteers. And our third question is, can we protect our community? Let's take a look here and say that what's happening in other sports at this point. So in the professional world, After shutting down initially, whether it be during the middle of the season, right as playoffs were about to begin, or even before the preseason spring training was going to begin, all the major professional sports took a pause, took some time to develop a plan, and now we get to see what that plan has, starting the results of those plans as they've returned to sport. So the MLB, since they've opened, they've seen about 37 games postponed related to coronavirus infection. They've had 104 positive tests, with the average age being 27. MLS and the English Premier League, during the initial preseason timeframe, they had cases, but then since then, the MLS hasn't had any new positive cases. The English Premier League has had a total of 20 cases in 14 weeks. The NBA seems to have effectively, and NHL seems to have effectively developed a bubble for their playoffs, and they don't report any new infections. The NFL so far has a positivity rate of about 0.46%, and that includes all coaches, players, and staff. So again, we're going to see more information as they continue to go through this, but we have to keep in mind that professional sports have a lot of resources. They're contracting with testing organizations to have for more frequent testing, and they're testing asymptomatic individuals as well. And really, this is part of their job. And so I think it's a conscious decision for these players, for the coaches, for the staff that have, and the umpires that have decided, is my job and the satisfaction and financial impact of this job worth the risk of coronavirus, and can we do that in this scenario? I think that's one of the factors for professional sport. Clearly, we don't have that in college and high school sports. From a college standpoint, you're probably aware the NCAA has canceled all fall championships for all 3 divisions. The Big Ten and the Big 12 have decided to cancel fall sports competitions, and that's driven in part by concern over cardiac concerns for COVID positive athletes. And we'll talk about that in a little bit, because I think that's really important for us to understand. The Centennial Conference locally, they've canceled fall and winter sports through December 31st, as well as the PSAC. And then looking for high schools, if we look at our neighboring states and what their organizations have decided to do, the Ohio High School Athletic Association is moving forward with sports without spectators. They are implementing mitigation efforts. In New York, they're delaying the start of fall sports until September, late September. New Jersey's delaying the start of fall sports. And then they're staggering their opening based upon the type of sport and the risk. Maryland is postponing fall athletics indefinitely. They haven't set a date, a firm date. And Delaware has postponed sports until December. The PIAA has stated that we will begin normal fall practices, and heat acclimatization began this week. We do know that in Pittsburgh so far this week in the WPIAL, there have been at least 2 football teams that have had to close down their scrimmages, which will ultimately delay their start of participation in their first game or first 2 games, and those were due to coronavirus positives. And here in our good old LL League, fall practices are to begin resuming on September 4th. So in regards to keeping our players safe, some of the health concerns for athletes, there are limited studies around this at this point. But one of the concerns that's out there is around myocarditis, which is inflammation of the heart. Now, myocarditis can occur after a viral infection in which the lining of the heart the heart musculature can become inflamed. This can obviously affect function. Not only can it lead to decreased performance, difficulty with breathing, and fatigue, but it can also lead to permanent changes in the structure of the heart. One of the things that we found with coronavirus so far is that in adults that are hospitalized, about 22% of them, of those cases, will have some degree of cardiac involvement, with myocarditis being the top cause. And compared to other viruses, that they only, in 1% of those hospitalized cases, would cause some degree of cardiac inflammation. So this falls in line with what we're understanding about coronavirus and its proclivity to cause cardiopulmonary disease or inflammation. And this is something we're continuing to monitor. We don't have many studies yet or much information opening up a window into how often is this happening with our pediatric or under 18 athletes. But the NCAA is aware of at least 12 cases so far of myocarditis among its athletes. And I think this was one of the big factors that played a role in the decision for some of these schools to hold off or delay the start of sport. We're not sure what the long-term effects from coronavirus are for a number of individuals. There are some adults that will experience symptoms that continue to last for several weeks, or they come back after it seems that they've resolved. And we're still understanding and a lot watching our testing techniques evolve as well. There has been some discussion about how do we return athletes back to sport after they've experienced coronavirus. And given the tendency in adults for myocarditis, the American College of Cardiology, as well as the American Medical Society for Sports Medicine and the National Federation of High School have all put together guidelines or statements that are pretty much in alignment around how do we return an athlete back after COVID based upon our current knowledge. And there's some scenarios based upon their symptoms where they may need to have an EKG or an echocardiogram. And sometimes they may need more advanced testing. If they've had more severe symptoms, they may not be able to return to sport for 3 to 6 months. So there's a lot more than just watching them become symptom-free before we allow our athletes to return back to sport. And I think the takeaway here for all of us is that we should be asking our students during their pre-participation exams if they have been infected or tested positive for COVID-19. We should also be making sure that they're following with their primary care doctors so that they have an effective evaluation and health history to know where they fall in these categories and if they need, what kind of workup they will need in order to safely return to sport. And I've had a lot of great conversations with athletic trainers in our area, and this is all on their radar too. And there's more questions that continue to come around about this. I think this issue will continue to evolve, so we'll just have to stay tuned to this and be in close communication. What is our current state here in Lancaster County? As I mentioned, one of the key questions is, can we keep our community safe? So I think it's important for us to know what we're dealing with. Right now, or at least as of Tuesday, based on the state of Pennsylvania early warning monitoring system dashboard, the good news is that our cases have actually dropped a little bit. We went from about 59.2 cases per 100,000 residents down to 43, which is a good improvement. And our testing positive rate dropped from 4.5% to 3.7%. So it does seem like recently we've made some strides. If you went back towards July, end of July, Lancaster was in a pretty rough spot. And at one point in time, we were one of the worst counties in the state. So I think hopefully this means that we're making good progress with social distancing and mitigation efforts, but we'll have to see how this pans out as we enter the fall and with schools reopening. This was an interesting study that was done, or that ongoing data collection done through CHOP crowdsourcing. And they were looking at cell phone data to determine how, over the course of 7 days, how well do people socially distance. And 14% was actually not very good. We would like to see that much higher. So back in the end of July, Lancaster County was actually doing worse than some of these other counties surrounding us as well. Hopefully that's changing, but interesting to be able to have that data. As far as testing goes, there are several different tests out there. Right now, what's considered the most reliable testing would be the PCR testing. This is obtained either through a nasal swab or a nasopharyngeal swab, and it really looks for the presence of a virus. It can detect very small amounts of the virus. But one issue with it is that some people will remain positive for 6 weeks or longer after infection, but we really don't think that they're, or it doesn't appear that they shed enough virus to be contagious after 10 days. So one of the issues as we're looking at maybe professional sports or some other businesses or colleges that have opted to do universal testing is that they're finding a number of people that may have had previous infection or had infection weeks ago but are no longer contagious. Makes it a little bit trickier in terms of how to manage that. Probably heard a lot about antibody testing. And essentially that's trying to look to see if you formed an antibody to COVID-19, does that mean that you were exposed to it before and infected with it in the past? And these came to the market very quickly, a lot of them without much solid evidence or proof behind them. And so they really haven't been shown to be extremely reliable to this point. So I think this is something that will maybe be more effective or may be more useful down the road. But at this point, we haven't really defined this as an important piece of making these return to play decisions or in terms of like reopening schools and returning to sport. Turnaround time plays a big role. Essentially, if we can't keep our turnaround time of testing to less than 7 days, it makes contact tracing efforts much less effective. So we have fluctuated up and down, and there's a lot of reasons for that. But currently, our turnaround time is around just over 2 days. As we start school, as we see more testing that could come from that, that turnaround time may change. I know that all of the health systems around here, well, specifically LGH, has been working with our testing centers to try and prepare for this, but we'll just have to continue to monitor this situation. As far as the schools in COVID, I'm sure a lot of you have already been familiar with what's going on from this standpoint, but the DOH has really said that, they've released these guidelines that put if based upon these different categories rather of transmission and risk in the community. And one thing I like to say is, we're only as good as the community we're in. So what is our community transmission rate and what risk category are we in? Department of Health, based upon our numbers, has us in a moderate risk category. And we would really need to get down to about less than 10 in 100,000 cases, or less than 5% positivity, which we're already at that metric, but we'd have to get down from 43 per 100,000 cases down to 10 in order to be in that lower risk. And this has an important effect on two things, because they have suggested that the type of instruction should be directed, of school instruction should be directed by these risk categories. But also, it dictates how we react if we start seeing cases and we're in this specific category. So if you're in a moderate risk category, which we are, and we likely will stay here for quite some time, once a school facility sees 2 to 4 cases of positives, whether that be a student, a staff member, then, and that's within a 14-day time window, then that will result in a closing of the school for or that facility for potentially 5 to 7 days. So, and during that time, all close contacts will be quarantined. So there's a real potential here that we could see closures of different school facilities. And I think that will have a big impact upon our decision around practices and sport competition occurring when we're seeing a different school closure. Penn Medicine and Lancaster General have partnered with the superintendents, the IU13 and the Lancaster County Commission to provide some resources for schools. I just want you to be aware of this, that all of your superintendents have access to these resources, which include frequently asked questions, standardized protocols, as well as the ability to do on-site walkthroughs. Specifically, as it pertains to sports, we do have some sports and athletic specific questions, and we're working on making that more available directly to athletic trainers. So more to come on that, but I want you to be aware that these resources do exist should you have questions that come up. It's just an example of some of the documents. One other document that we created was an athletic health and safety plan. So as you're aware, the Pennsylvania Department of Education required that an athletic health and safety plan be developed based upon their template and then approved by the school boards prior to resuming practices. We kind of went through that and put together what a model health and safety plan might look like. So for anyone that is interested in kind of referencing their plan with where our synthesis of the information is, this document is available for review. So after discussing a little bit about what the current state of COVID is in our community, understanding some of the risks and the knowledge gaps for our athletes around coronavirus, and also knowing a little bit about how this could impact our staff and our coaches, we need to talk about risk assessment, because our decision ultimately on whether and how to have sport will come down to synthesizing that information and putting a risk assessment together. So we really need to see, how do our mitigation efforts stack up? How well are we doing with masking? How well are we doing with encouraging the right type of masks? How well is our community doing? And how does that interplay with what our athletes and coaches are? We can talk about what are the risks for not having sport. I think all of us are on this meeting because we have a deep appreciation for sport, and we understand that it's vitally important, that exercise is vitally important for these kids. And so we never want to discount that. And exercise has even been encouraged through the pandemic, but I think there are safe ways to do that. And there are also different risks associated with different types of exercise and sport that we need to be aware of. We should be asking ourselves, what are the risks for the schools if we're opening sports at the same time? And I think one thing we've seen is that a number of athletic associations or even school districts have decided to delay or stagger their start to opening sports. And part of that, I believe, is just to try and do a phased reopening so that we can see how school and instructional learning is going first before we start introducing some of these other extracurriculars. One of the concerns too is about our risk to family members that has maybe at a higher risk, that has some cardiopulmonary issue or an immunosuppressive issue. How do we, what responsibility do we have to make sure that the athletes or coaches are aware of those risks? As I mentioned before, what is the perceived risk? There's a lot of information and misinformation out there, especially on social media. I think it's easy for our student athletes and even for coaches and administrators to get wrapped up in some of this. And honestly, even for our healthcare providers to have a hard time distinguishing what may be evidence-based, fact-based, and what may not be. And I think we all come with our little bit of our preconceived notions about what coronavirus means and what the risks are and what we're willing personally to take. And it's challenging to kind of set aside those personal biases to be able to do these risk assessments. So stratifying sport activities based upon sport and skill may be another tool that we can use. And the Aspen Institute has published a document that's reflective of most high school sports, and it stratifies activities based on each of these sports. This is just an example of field hockey and kind of outlining what may be lower risk skill sets within field hockey and what may be higher. Some programs, some school districts have included risk stratification as part of their athletic health and safety plan, and maybe something that we should consider providing information to or direction for individual coaches and individual sports. So putting all of this together, I just want to touch base on a few action steps that maybe we can take moving forward, or at least make sure that we have in place. And again, this is all coming from the framework or the viewpoint that in another month from now, our scenario is probably going to look different than where we're at right now. And we need to be in a position where we can respond timely and effectively and have that process in place. And I think as a part of that, clearly defining your athletic pandemic response team is going to be crucial. And knowing who are those members of the athletic pandemic response team and how they interface with the school pandemic coordinator or response team. Personally, I think that you should have key stakeholders as part of the athletic pandemic response team. And that would include, but not limited to, athletic directors, athletic trainers, your school physicians or team physicians, and potentially even the school nursing. Identifying who the response team is one piece of it, but communication is so critical too. So kind of having a clear understanding of how information from our coaches and from our student athletes and even from our parents are going to filter through on the athletic side of things so that the right information is getting to the athletic pandemic response team in a timely fashion. And so it may take a little bit of work and a lot of education, but I think having those communication pathways defined will be really critical, especially when if things get really crazy. This will help. I do think we need to be encouraging and modeling what we know to be effective mitigation efforts. Masking, hand washing, distancing. I think looking at not just what masks can we wear, but what are the best masks that are effective. Playing sport and being allowed to have these extracurriculars is a privilege, and we want to preserve that. And if we can really build that culture into our administration, our coaches, our health, athletic training health staff, our students, and the parents of these students, and that'll help all these school districts be much more successful with our sports programming, because now they have buy-in and they can see what we're doing, the actions that we're taking make a difference as to whether we can or cannot continue to participate and have these sport. I would also encourage you to identify the staff that may be at high risk, that have conditions, and even these students that might be at higher risk, student athletes. I know a number of the pre-participation exam packets that I've seen from school districts in our area have had high risk check sheets so that The athletic trainers are at least aware potentially of who may have a high-risk condition. And I think that just provides an opportunity, one, for a conversation, either with the athletic trainer and that student, or encouraging them to talk with their healthcare professional about being at higher risk. And then us being aware that we may need to provide different or more virtual or individual skill set and drills to protect those people. And finally, as much as you can, developing cohorts and being able to trace contacts can make a big difference. So I think we've already seen an example from high school where practices, they had a sport that was doing preseason or open practices, and masking and socially distancing was not, and cohorting wasn't happening with the students. And unfortunately, when a positive test came back for one of the players, then the entire team had to be quarantined. And that has then caused a delay in them being able to start school, but also in them resuming practice. One way to protect this is by cohorting groups. So defenders practicing together with defenders, linemen practicing only with linemen, and doing that as much as you can and trying to think creative and be creative around that. Because if there is a positive case, then you have been able to contact trace, meaning we're keeping a log or an idea of which groups of athletes are working with which other groups, then you're going to be at less risk of an outbreak on that team and at less risk of having to quarantine individuals for long periods of time. Remember that we're not recommending asymptomatic testing. So if someone had a potential exposure, they're quarantined for 14 days without getting a test. Now that changes if they develop symptoms, but that's, 2 weeks, that's a big sacrifice. So I really think that these are effective ways that we can implement some changes in protection for our athletes in our sports. Well, thank you for your attention, and I really thank you for everything that you all do for looking out for our athletes, for providing safe and providing equal opportunity here in Lancaster County for our student athletes. And if you have questions at this time, I'll look through the chat box and see what we have here, okay? So one question is, are children with the patent foraminal that's a defect, a hole in the heart that you can be born with, are they at more risk due to COVID-19, and would they see more severe symptoms? Well, this is a great question. I had a conversation with some of our peers from CHOP Cardiology earlier this week, and we are going to be working together to more clearly define who are high-risk individuals, like what conditions in the pediatric population are high risk, and then also looking at these different return to play considerations and what the best pathway is for returning an athlete safely to sport after COVID-19 infection. Specifically for PFO, I think this is not necessarily identified as a high risk, but it's probably, if they have established care with a cardiologist, I think it's worthwhile for them to have a conversation with their cardiologist around that condition. And this would also apply for those that have other defects in the heart septum, such as atrial septal defects. I think it's important that we at least encourage them to have a conversation with their primary care physician and or cardiologist around the risks of returning to sport. I have another question here. What is it about the virus that makes an Alzheimer patient high risk? So we do know that coronavirus seems to cause in some individuals some neurologic conditions. Not that it causes Alzheimer's, and I don't mean conditions, neurologic symptoms, such as brain fog, etc. And we're not sure how much of that is related directly to their cardiopulmonary change, like maybe because their cardiac performance or their oxygenation isn't as good as it was before. Maybe that's contributing to some of the brain fogginess. But there does seem to be some group of individuals infected with coronavirus that will have some neurologic symptoms. Alzheimer's specifically, in addition to that, I think there may be concerns about the age in general for Alzheimer's patients. Not that you can't have Alzheimer's at an early onset age, but anyone that's over age 65 is considered higher risk for having a more serious coronavirus infection. I think that plays a role into that consideration. So another question here, if a team does have to shut down for 2 weeks, how soon is it safe to resume competition after potentially being deconditioned for 2 weeks? So there's 2 points I want to make here about this. This is a great question. One is that the Department of Health has really made it clear that they are the ones that are going to help with schools make the decisions about closing down sport or classrooms or facilities. So any positive cases will be reported to the Department of Health. Now the turnaround time from when that case is reported to the DOH and how quickly we get a determination for the school or the sport team, that remains to be seen, especially if we don't get the results back until a Friday or a Saturday. And now what do we do over the weekend, et cetera? So your school physicians and should be, and your athletic pandemic response team should be involved in that decision process of what are we going to do in the meantime while we're waiting to hear back from the Department of Health regarding shutting down practices. But honestly, I think it's probably best to err on the conservative side if you are having a positive case and you're not readily able or reliably able to identify cohorts that could rule out so close contact with other members of the team. The second part of this question is about, is it safe for them to resume competition after not participating for 2 weeks? Well, first of all, the members that do test positive or do become infected during that time period, they should have a medical evaluation and be cleared by their medical provider before returning. As a part of that, there's also been discussion of a return to play protocol for athletes that have been infected with COVID-19. And the British Journal of Sports Medicine has released some guidelines around that. Internally here with Penn Medicine, Lancaster General Sports Medicine, we are developing our own protocol based upon that in partnership with our CHOP cardiologists. But I really just want to stress that any positive cases should be cleared by their physician before returning to sport. And as a part of that clearance, you should be looking for a return to play protocol. If there isn't a return to play protocol that's built into that, then I suggest consulting with the sports physician at your school or with a sports medicine provider. And for those that were not positive cases of coronavirus and were just quarantined for 2 weeks, I really think this kind of goes back to what are our risks coming from the summer and starting sport. We know a lot of individuals, they don't necessarily train very much over the summertime. And then we see a number of athletes that just, come and return to sport without much conditioning to begin with. And many of them present somewhat deconditioned. So I think it's probably good for coaches to be aware that maybe we need to step back. If this happens during the middle of the season, maybe we can't continue right where we left off in terms of the degree of conditioning we were doing. We may have to step back a little bit and then build that base back up. So I'll give just a couple more minutes here if there are any other questions. Just remember, there are no dumb questions, just dumb answers. But I'll try to, not make it too dumb for you. Great. Well, I don't see too many more things coming in. I really appreciate everybody's time and attention. If you have any concerns or questions, you may feel free to reach out to me. If you would like to discuss anything specific beyond this, I'm happy to be a resource for you. As I mentioned, Penn Medicine Lancaster General Health does have a resource page that the superintendents have access to. And a part of that will have sports and athletic specific questions and answers so that you can reference those as well.
All right, so if you guys, go ahead. Sorry, Pat.
I was just going to say good luck to everybody.
Good. So if you guys have any other questions that you think of, you can feel free to at Penn Medicine, and we just want to say thank you again for joining us tonight. This was recorded, so the link will be available on that Google Drive document, so you'll be able to access this and go back at any time to review the slides that Pat showed, as well as see any answers that he has to the questions. So thank you guys so much, and have a great evening.